Okay, today we're going to start pediatric IV therapy. IV therapy to children is going to be one of the most challenging experiences that you'll ever have, and it's going to be one of the most memorable for the child. Either it will make them completely comfortable and at ease when they are ever hospitalized again or have to deal with IV therapy, or they'll be completely petrified. Your skills and the way you handle them will determine how they react later in life as well. IV therapy for children is prescribed typically to administer medications, to correct fluid volume deficits, to improve serum electrolyte balance, or to provide nourishment. Your first concern with doing a IV on a child is that you have to correct the site and equipment that's appropriate for the therapy and the child's age, size, and activity level. You typically choose a scalp vein for very young infants, and then the older the child gets, you have to take into consideration how much movement they're going to have, and that you're going to probably choose a peripheral hand, wrist, or foot vein for them instead. Choosing an appropriate site is more difficult in them because the veins are smaller and have more subcu tissue that covers them. You'll have to know the children's vein anatomy in order to make it easier for you to find a vein to do this IV therapy with. Okay, the first thing that we're going to talk about for IV therapy for children is replacing body fluids or correcting electrolyte imbalances. Children can become dehydrated very, very quickly, and they also develop electrolyte imbalances extremely quickly. It usually happens when they have vomiting, diarrhea, fever, or other disorders that affect the body fluid or electrolyte levels. The first thing that I want to mention to you is on page 293. There's a chart that has common fluid and electrolyte imbalances in pediatric patients. The first one we're going to talk about is hypovolemia, which is a fluid volume deficit. And its causes are dehydration, vomiting, diarrhea, decreased oral intake, and excessive fluid loss. And those can happen for a lot of different reasons, but you do need to know what the causes of hypovolemia are. The signs and symptoms for a child then are going to be thirst, oliguria or anuria, dry mucous membranes, weight loss, sunken eyes, decreased tears, depressed fontanelles in infants, tachycardia, and an altered level of consciousness. So the treatment then for hypovolemia is oral rehydration in mild to moderate dehydration, and then IV fluid administration in severe dehydration or electrolyte replacement. I am not going to ask that you know the rest of the chart now for hypernatremia, hyperkalemia, hypokalemia. Right now, just hypovolemia. Okay? I do want you to know, though, that some of the signs of electrolyte imbalance can be arrhythmias, altered respiratory effort, and muscle spasms. And the types of signs and symptoms that they have can estimate the severity of the condition. To maintain fluid and electrolyte balance in children, you have to remember that you need to adjust the maintenance fluid volume based on the condition, the treatments that are ongoing, and the ongoing losses such as vomiting, diarrhea, and insensible losses through respiration and sweating. Now, when administering blood or blood products in a child, most children who need blood or blood products have bone marrow failure, severe anemia, sudden loss of blood, a low hemoglobin level before, during, or after surgery. Most of the time they might get whole blood transfusions because they replenish both the volume and the oxygen carrying capacity of the circulatory system, because they increase the mass of circulating red blood cells. On page 295 is the blood administration guidelines. You will need to know whole blood, that the indications for whole blood are massive blood loss, exchange transfusion, or special procedures, and that the rate it's given is as rapidly as necessary to reestablish the volume, usually 45 to 60 minutes longer if they're hemodynamically unstable. And the guidelines for it are to administer the ABO group and the RH specific type. That'll make more sense to you after we do blood and blood products. But for right now, I want you to know that. Also, for children, you can give them packed red blood cells, which are just concentrated red blood cells with most of the plasma, leukocytes, and platelets removed. You're indicated to give packed red cells in severe anemia, surgical blood loss, and suppression of erythropoiesis, and ECMO. Okay. For packed red blood cells, you give them at the rate of 5 milliliters per kilogram per hour. Again, you have to make sure that you have the correct ABO group and are each type specific. And that O negative uncross-matched blood can be given for infants up to age 4 months. You do not need to know the rest of the blood guidelines for now. You may also do IV therapy on a child that needs to maintain nutrition. They're unable to obtain adequate nutrition requirements either orally or through a gastrostomy tube. You'll have to give them parenteral nutrition, and we'll talk about TPN at a later time also. Right now, you need to know that nutritional formulas that are delivered by IV infusion contain water, glucose, amino acids, lipids, electrolytes, vitamins, and minerals. Sometimes you may have to administer medications to children. An IV medication may be given to a child when they can't take medications orally. The oral route changes the drug or interferes with its ability to be absorbed by the GI tract. The drug isn't available in another form, or it's too irritating for IM administration. And rapid therapeutic action is needed, such as an emergency. We've talked about IV therapy a little bit, and you know it's the fastest, most efficient way to deliver medications. Sometimes it's the most expensive also. When you administer IV therapy, it's done either as a bolus, which is a concentrated dose given all at once, or as a drip or a piggyback, which is diluted with an IV solution and given over a predetermined time. Most chemo drugs are given by IV therapy. Calculating the fluid replacement needs for a child is an extremely complex process. It requires that the practitioner perform a thorough assessment and consider many factors before ordering a type and amount to be infused. As the nurse, it is your job to double check the order for accuracy and ensure that it meets all the child's needs but does not put them at risk for fluid overload. Any miscalculation, even in the slightest, can cause a child to go into fluid overload in a very short amount of time. Generally, replacement therapy is based on the child's stage of dehydration, which are classified as mild, moderate, or severe. The most accurate way is to take the child's current and immediate pre-illness weights in kilograms, and then there's a calculation on 297 for you to go by. All I want you to know at this moment is that mild dehydration is 3% to 5% of loss, moderate dehydration is 6 to 9%, and severe is greater than 10. You do not have to know how to calculate the percent of fluid loss, but you do have to know what the definition of mild, moderate, and severe are. On page 298, there's a chart that are clinical signs and dehydration severity. A few of the things we've already talked about, but some of the ones I want you to know are the vital signs. So in a child who has a mild dehydration level, the heart rate is normal, the blood pressure is still normal, the pulse is still normal, and the respirations are still normal. So you've got to look for other signs and symptoms. Now in a child who has a moderate dehydration level, the heart rate is slightly increased. The blood pressure may still be normal, or it could possibly be hypotensive. The pulse is thready, and the respirations are slightly increased. In a child with severe dehydration, the heart rate is rapid and weak. The blood pressure is hypotensive. The pulse is faint, and the respirations are increased. Right now, we have not done any kind of pediatric lecture that's coming later. So right now, you do not know what the vital signs for a child are normally. So that you just need to know that a blood pressure is either normal, that it's possibly hypotensive, and that it is hypotensive for the different degrees of dehydration. And when we do pediatrics, you'll know what those levels are. Then those vital signs should be. Again, you do not have to know any of the calculations. Just remember that when you are calculating fluid, or when fluid needs are being calculated, that you have to consider the losses, again, for diarrhea, vomiting, diaphoresis, hyperthermia, and from NG tubes and drains. So that's why it's important to make sure that all of those things are recorded and calculated accurately, so that the amount of fluid replacement can be calculated accurately as well. Okay, when administering IV therapy to a child, you have to remember that they require special care during catheter insertion and throughout the therapy. The venipuncture technique is going to be basically the same for most pediatric patients, but your approach, the restraint method, and the manner of securing the IV catheter will depend on the child's age and medical condition. You'll have to monitor the child closely during therapy to determine whether the fluid is infusing correctly to prevent fluid overload, infiltration, and other complications. We mentioned that the greatest challenge is going to be choosing an appropriate vein. Veins of infants and toddlers are usually very difficult to visualize or palpate, especially if that child is already dehydrated or hypovolemic from a medical condition. Also, toddlers and prepubescent children tend to have more subcu fat that covers their veins, and that makes it even more difficult to figure out where a vein is. When choosing the IV site, you're going to again consider the age, the activity level, and the reason for therapy. Other factors that you might want to consider are how difficult the venipuncture will be for you and the patient, which site carries the lowest risk of device-related systemic infection, and you should always avoid previously used or sclerotic veins. I think that's a given with anybody. If a child is less than 12 months old, scalp veins are readily accessible for short peripheral catheters because they have no valves. They're easy to stabilize. They're best reserved for infants younger than 6 months old because they become easily dislodged by the child's hands if the child is very active. To locate an appropriate scalp vein, you have to carefully palpate the site for arterial pulsations. If you feel pulsations, you select another site. However, if the infant is hypotensive or premature, the pulse may be more difficult to detect. So you have to think about those things. The dorsal surface of the foot and the lower leg are also good sites for children prior to walking age. Femoral veins can be used for children of all ages, but best when used when the child is in a diaper. But you've got to remember to keep the site as clean as possible to decrease the risk of infection.